Okay guys, let's get started on the concept of cellular regulation, which starts on page 31 in your book. Please remember that it is your responsibility to review the anatomy and physiology on your own, and that would be from pages 31 to 34. Take a minute to look over the learning outcomes for the concept of cellular regulation and realize that these are always a good resource when you guys are looking to study for your exam. Okay, we want to make sure that you understand the terminology listed on this slide. So the terms are from mainly page 34. Now the last three terms, myelosuppression, neutropenia, and thrombocytopenia, are actually on page 41 in this chapter. Just realize that myelosuppression refers to suppression of the cells in the bone marrow. Neutropenia is when you have an absolute white blood cell count less than 500. This places your patient at risk for infection. And thrombocytopenia is a platelet count that falls below 10,000, places your patient at risk for bleeding. Next, I want you guys to turn to page 35. There are some disease processes associated with cellular regulation. The first one listed on 35 is cancer, for instance, and we're going to cover that as our exemplar. Next is anemia. You guys understand there's several different types of anemia, but overall it's a deficiency of hemoglobin, or it is a reduction in the overall number of red blood cells. And then this causes the issue of inadequate delivery of oxygen to the cells and the tissues and organs. Leukemia is actually a form of cancer. It's a form in which the bone marrow produces an abnormal number of white cells and does so in a manner rapidly. And then there is sickle cell disease, which we know is an inherited condition that leads to a deformed red blood cell that causes multiple issues. And polycythemia, poly meaning many, we have an abnormal increase in the production of red blood cells, and this causes the blood to be thick. So you guys can review these alterations and manifestations on page 35 on your own. Okay, so when we talk about concepts that are related to cellular regulation, we're on page 37, and first we talk about advocacy, which relates because the nurse needs to make sure that they advocate for the patient and the family for proper education, because proper education leads to the selection of proper treatments. Next, infection. Infection, one way is related because of the various treatments, such as chemotherapy, can lead to a suppressed white blood cell count, which we called neutropenia in the previous slide. And when someone has neutropenia, it places the patient at risk for infection. Also, for instance, someone with leukemia, while they produce a high number of white blood cells at a rapid rate, these white blood cells are immature and place the patient at risk for infection. Inflammation. Inflammation is the result of trauma, and there is a lot of activation of the inflammatory response during treatments, for instance, and this leads to increased production of white blood cells. And then managing care. When I think of managing care, I actually think about the inherited disorder, sickle cell anemia. This is a lifelong disease which needs a lifelong approach to manage care. And then last, there's stress and coping. So you have physical and or emotional stress. We know that this often can lead to an increased risk for the development of other diseases and disorders. You guys can take the time to review page 37 and review the related nursing implications. We want to focus on health promotion when we're talking about cellular regulation. There are certain things that we consider modifiable risk factors that would decrease a patient's risk, for instance, in developing cancer. So we could focus on, obviously, telling them to not smoke or use tobacco products and to limit their exposure to secondhand smoke and air pollutants. We want to focus on a poor diet. This is an issue in the United States. We lack fresh fruit and vegetables in our diet. We consume too much fat and processed foods. We want to encourage physical activity. We want to focus on and encourage patients to maintain a healthy weight. We want to avoid sun exposure. This is especially true because we live in the state of Florida. So we want to make sure that we teach them how to protect themselves from ultraviolet radiation. And so, for instance, in Florida, this means don't get sunburned. Make sure you don't go outside during the time of day when the sun is the strongest. Make sure that you use SPF that is at least 15 or greater, and that you reapply frequently. We want to make sure that they understand that if they do have sun exposure, that they want to watch for changes in any lesions on their skin. Encourage them to avoid risky behavior. I say this because we know that hepatitis B and C, for instance, results from risky behavior and can lead to instance for liver cancer. Homes that were built not recently need to be tested for radon exposure, and stress the importance of getting immunizations, regular medical care, and doing self-examinations. There are some things that are non-modifiable. We know that, for instance, that being a female is non-modifiable and a male, and that these place us at risk for certain types of cancer. So self-breast exams for men, going in and getting their prostate exams, prostate screenings, paying particular attention to these types of cancers that we know can have a hereditary component. And then we want to encourage patients to know about screenings. The American Cancer Society and several other organizations have set forth screenings that we know help prevent or catch cancer early. And I have actually hyperlinked into this slide these screenings. Instance, we know that for a patient who has no family history of colon cancer, that at the age of 50 they should have their first colon screening. As a nurse, it's your responsibility to constantly observe for signs that a patient might be developing or has developed cancer. So we're observing for these because we know that early intervention and treatment is going to improve patient outcomes. Things that we should monitor for cancer would include change in bowel or bladder habits, a sore throat that doesn't heal, unusual bleeding, a thickening or lump in the breast or elsewhere, difficulty swallowing, and changes in a wart or a mole, or a nagging cough and hoarseness that does not subside. And during your physical exam, you certainly want to observe for a couple of different things. One would be the development of an activity and intolerance, which could tell us that the patient is suffering from anemia. And two, we would want to observe for or ask about a weight loss, and then explore whether the weight loss was intentional or unintentional. As far as diagnostics, we'll talk a little bit about these in the exemplar of cancer. So just real briefly, we're always concerned about trying to find where our primary site is. And so we find the primary site, and then next we need to see if it has spread or if there is metastasis. Anytime you guys see cytology, just know that it's the study of cells, and there are many different cells that we can actually take and look at to see if they are abnormal. You can get a biopsy of tissue in a multiple ways. So for instance, in class we talked about a bronchoscopy, and we talked about that particular bronch where the patient was suspected of having lung cancer, and we utilized bicep forceps, and they went down and took a piece of tissue which will be sent off to the lab so they can see if there's abnormal cell growth within that sampling. As far as there's numerous different radiology studies and scans that can be done. Now, you guys should know about CAT scans. We've talked a little bit about CAT scans and the injection of a potential dye. and what you would need to look for prior to the patient going down. A PET scan is a little bit different from a CAT scan. It actually utilizes a radioactive tracer. This tracer can either be swallowed or inhaled or injected, and the tracers then collect where there's higher chemical activity, such as rapid cell proliferation, and so that would show up as a bright spot. And so just realize the difference in a CAT scan and a PET scan, and that PET scans are not useful in all types of cancers. The next slide, we're actually going to talk about bone marrow examination. A bone marrow aspiration or biopsy is actually where we take a sample of the liquid part of the soft tissue inside your bone. What we know is that this is where we can find your white blood cells, your red blood cells, and your platelets. So what usually leads to having a bone marrow aspiration is a patient shows up with an abnormal CBC. Either they have their white count is abnormal, their platelets, their red blood cells, maybe all three. And we know that certain conditions produce these abnormalities. The anemias, for instance, the leukemias, multiple myeloma, lymphomas, and there's a need to actually get a sampling of the bone marrow. So a patient can have a bone marrow aspiration done in a physician's office. Often when this is done in the physician's office, what they do is they take a sampling from the iliac crest, and so the patient is placed in a sideline position. The site is cleaned, the patient's skin is numbed, and then they insert a large porous needle into the iliac crest and aspirate some of the contents and send it away for further diagnostic testing. So I have linked in a bone marrow aspiration on this slide, and there's also one on the YouTube channel. Post-procedure, this is done without sedation, and so a lot of times the patient is sent home. They have a pressure dressing put over the site. This is particularly important if the patient is suffering from thrombocytopenia, and so we know that they could be at risk for a site infection, so we need to explain to them how to monitor the site. At risk for bleeding, especially if their platelet count is low. Pain is usually minimal, but you could, if no contraindication, suggest that they take acetaminophen or ibuprofen. And just remember that it is an in and out procedure. For the monitoring of labs in cancer, we have some labs that we use for diagnostic purposes. Those are called tumor markers. A tumor marker can be found in blood, urine, or body tissue. It can be elevated in the presence of cancerous cells, and so the first four, the CEA, the AFP, the CA125, and the PSA, those are all examples of the tumor markers. And so these guys might be elevated and suggest that there's a cancer. Not always, but when they do come back elevated, we need follow-up. And so, for instance, the CEA can and exist in the GI tract, the AFP, the liver, the CA125 could be suggestive of ovarian cancer, and the PSA prostate. And so we would need further diagnostic testing. We've talked about the CBC, and the CBC often comes back elevated when, for instance, there's a leukemia and there's rapid growth of the white blood cell count. And then LFTs could be altered, for instance, if someone has liver failure or has a liver cancer. Independent nursing interventions related to cellular regulation. I think that we have to realize that when a patient receives a diagnosis of a disease like sickle cell disease or a cancer, a leukemia, the patient and the family really don't hear anything past you have sickle cell disease or you have cancer on that initial contact. So it's important that as the nurse we're prepared to repeat the information that was provided to them, give them written material, and they need to especially understand what comes next. After the initial diagnosis is processed, then they'll be ready for additional information, more so on the disease, the treatment, the potential outcomes, and the suggestion of support systems. It has to be timed correctly. When we look at healthy coping, the majority of individuals will respond with anxiety. And so we just have to make sure that we're monitoring for the anxiety, and that they have processed, accepted the diagnosis. We need to assess for their previous coping skills, strategies, and if these were effective techniques, then we need to encourage them to continue to use them. If not, we need to supply them with new coping techniques, strategies. Just remember, we are responsible for education. We've already talked about modifiable risk factors. We need to make sure that we are educating individuals about these modifiable risk factors and encouraging patients to get the screenings that are recommended by the American Cancer Society and the other associations. Now we're moving on to collaborative therapy, and we're going to talk about surgery, chemotherapy, and radiation, and then a couple of other potential collaborative therapies that could be used. We're going to specifically look at collaborative therapies that are used for the treatment of cancer. So surgery is used in the majority of the time for a diagnosis of cancer, about 90% of the time, and that's because we need that biopsy of tissue to send to the lab so we can understand what type of cancer we're dealing with. And then in the actual treatment, it is used 60% of the time. And so when I look at this, I think of, for instance, a female who has a diagnosis of breast cancer. There was that initial breast biopsy that told us what type of breast cancer the patient had, and then possibly there's going to be surgical removal of the tumor, or even maybe the entire breast, which is a mastectomy. There are times that surgery is just used as what we call palliative therapy. Palliative means that it's used to increase the patient's comfort. I think of this when I think of someone who has a large, let's say, cancerous tumor in the colon, and it's causing an intestinal obstruction. Then the surgeon could actually go in and do what we call a debulking of that tumor, meaning that they're not actually removing the entire tumor, but they're decreasing the size of the tumor so hopefully stool could pass through. Chemotherapy is a cytotoxic med. It kills cells. It can be used to cure, that's always the goal, or it can be used to just decrease the tumor size, or it could be used as palliative therapy. And radiation is used in the same manner. It could be used to kill the tumor, it could be used to reduce the size, or in palliative therapy where it could be used to hopefully relieve pain or obstruction. Sometimes chemo comes before surgery. Sometimes radiation therapy comes before surgery. It just often depends on the cancer diagnosis and what the potential outcomes are. A couple of additional collaborative therapies would be biological therapy. Biological therapy is treatment that's made from living organisms or organisms created in the lab, and they can be utilized to either suppress or activate the immune system of the patient. And there are different examples of biological therapy. There's immunotherapy, and there's, for instance, gene therapy. What we know is it's less toxic, for instance, than chemotherapy. As far as the management of side effects, we're actually going to review an article in class that deals with the management of side effects, which can be numerous. It does talk about nutrition, though. Nutrition is critical in the management of a patient who is going through cancer treatment. We know that cells cannot heal without adequate nutrition, and so we need to, one, assess. We need to make sure that we assess for nutritional deficiencies. We identify the nutritional deficiencies. Then we need to make sure that we monitor them, typically with labs and weight and food intake and hydration status. And we need to make sure that if our approach is not working, that we come up with a new approach. When we talk in class, we'll talk about the management of nausea and vomiting, which can often interfere with a sound nutritional status in a patient that's dealing with cancer treatment. When you guys think about infant children and adolescents that are dealing with cellular regulation issues, just remember that no matter what they are dealing with, that we still need to continue to assess for their developmental milestones that you guys have learned about. We need to also make sure that we educate the patient, if relevant, and the family about the potential issues that could occur post-treatment. So for instance, I particularly think of some of the different types of surgery that could interfere down the line. A lot of abdominal surgeries, for instance, can result in scar tissue that needs to be monitored for. Chemotherapy sometimes can alter reproduction potential. So we want to make sure that we educate properly. We want to acknowledge the fact that the emotional response will vary with the age group. So for instance, when you're looking at adolescents, you're looking at an age group that could deal with the diagnosis of a chronic disease such as sickle cell disease, or a cancer with anger and potentially withdrawal. I linked in a site, it's the American Cancer Society site, that deals with or talks about the most common types of cancers in children. When we're looking at the elderly population, often what happens is their comorbidities, their hypertension, their diabetes, their heart failure, their COPD, complicate treatment. So for instance, someone could need surgical intervention for a cancer, but their medical comorbidities make them a poor candidate for surgical intervention. And I've also hyperlinked into the slide the cancers that are most commonly occur in the elderly population.